Imagine injecting your own blood,
Right.
right, like into your most sensitive tissue, only to be told you have to wait 2 full months to feel it actually work.
Yeah, it completely goes against how we usually think about medicine.
Right, because we are so conditioned by modern medicine to expect the instant fix. You get a headache, you swallow a pill, and 20 minutes later, the pain is just gone. We love that binary before and after
But
moment.
absolutely.
But today, we are stepping into a world where that instant fix mentality doesn't just fail, it actually sabotages the entire process.
It's really the friction between a mechanical approach to the human body and a biological one. I mean, we often want to treat our biology like we treat our cars, just swap out a part, tighten a bolt, and drive away.
Yeah, exactly.
But human tissue just doesn't work that way, especially when we are talking about actual cellular regeneration.
Which brings us to the very core of our deep dive today. And, whether you are a medical professional or maybe a patient exploring your options, or honestly just someone fascinated by the cutting edge of regenerative biology, you are going to want to hear this.
It's a fascinating area.
It really is. So we're looking at this massive stack of clinical trial listings, medical guidelines, med spa protocols, and practitioner commentaries surrounding the OSHOT. That is the platelet-rich plasma or PRP treatment for female sexual function and urinary health.
And it is a topic completely buried under just an avalanche of marketing noise.
Oh, yeah.
If you look at the billboards and the glossy brochures, I mean, the OSHOT is routinely pitched as this magical one-and-done fountain of youth for the pelvic floor.
Right, like coming on your lunch break and please completely transformed. Okay, let's unpack this, because our specific mission today is to cut right through that marketing hype and answer a highly targeted clinical question based on the actual data we've gathered, which is, what exact clinical criteria indicate a patient shouldn't just get one shot, but actually needs to undergo a 2-session OSHOT series spaced exactly 6 to 8 weeks apart?
And that distinction is just paramount because the clinical data reveals a biological process that is deeply nuanced and highly cumulative.
Right.
If you don't understand the timeline of how human tissue rebuilds itself, you really cannot possibly understand how this treatment works.
So to get to the bottom of why someone might need a second treatment, 2 months down the line, we have to look at what the body's physically doing during that first one.
Right, you have to establish that baseline.
Yeah, and I was reading through the clinical trial protocols, specifically the ones using the Arthrex Angel centrifuge system, and I was really struck by the physical process itself.
It's pretty specific.
It is. So they draw about 40 milliliters of your own blood, which is, just a standard blood draw, but then they spin it down to isolate just 2 to 4 cc's of what the texts call, let me get this right, leukocyte-rich, platelet-rich plasma. Now, I know platelets are involved in clotting, but what exactly are leukocytes doing in this mix?
So leukocytes are just your white blood cells.
Okay.
Their primary job is immune defense, but in the context of tissue repair, they act like the demolition and cleanup crew at a construction site.
Oh, interesting.
Yeah. So before the platelets can come in and build new tissue, the leukocytes have to clear out dead cells and, prepare the local environment. So when you inject leukocyte-rich PRP, you are delivering both the cleanup crew and the builders to the exact same site.
And the site itself is highly specific, right? The protocols note they use a tiny 25-gauge needle to inject this highly concentrated liquid into the anterior vaginal wall about 3 centimeters from the urethral meatus, which, if I'm understanding the anatomy right, is just the medical term for the urinary opening.
That is correct. Yeah, they inject near the urethra and into the periclitoral region. The whole goal is to bathe those specific tissues in just a massive concentration of your body's own endogenous growth factors and cytokines.
Cytokines. Okay, I saw the word cytokines everywhere in these sources. Are those basically just like chemical messengers?
Yeah, think of cytokines as cellular text messages.
Okay.
When they are released into the tissue, they essentially pull out a megaphone and start texting all the local dormant stem cells, telling them to, basically to wake up, replicate, and start generating new collagen, new blood vessels, and new nerve endings.
Wow. And for a lot of people, the results of that single cellular text message are pretty staggering. I mean, the surveys in our sources estimate that for women who have never experienced an orgasm in their lives, this single treatment helps them achieve 30 to 40% of the time.
This is incredible on its own.
Right. And for women dealing with diminished sensation or less satisfying orgasms, it helps restore that function around 80% of the time.
And those statistics right there, that is precisely why the one-and-done myth is so pervasive.
Right. because it works for a lot of people.
Exactly. For a majority of patients, roughly 65%, according to the Data One treatment, actually is enough to reach a level of satisfaction they are happy with. Their symptoms are mild enough that a single biological signal, gets the job done.
But calling it a shot still feels like kind of a misnomer to me because, like, a shot implies immediate drug delivery. Taking a pharmaceutical injection, like a painkiller, is like drinking an espresso.
Right.
You take it, and 20 minutes later you have an instant, undeniable jolt in your system.
Mm.
But based on how you just described those cytokines, the O-shot isn't an espresso at all.
No, not at all.
It feels more like planting a seed in a garden. You put it in the ground, but you aren't going to have tomatoes the next day. It takes a whole season to actually grow.
That is a much, much more accurate framework. PRP is not a drug.
Right.
The platelets are releasing those growth factors, which are essentially these small amino acid peptide chains. And you can think of those peptide chains as a highly complex blueprint. When they are injected, they aren't doing the repairing themselves. They are handing the blueprint to your local cells.
Oh, I see.
Right. And once that blueprint is handed over, the body has to manually source the materials and physically build the new nerves and blood vessels. You simply cannot rush biology.
So if the PRP is just delivering a blueprint, the obvious question is, how long does it take the body to actually read that blueprint and build the house?
Yeah, that's the big question.
And the sources outline a very specific biological timeline, right? The 3-day, 3-week, and 8 to 12-week milestones. And I was actually really confused by the 3-day milestone.
Oh, the acute phase.
Yeah. Why would someone experience worse symptoms, like bladder irritability or extreme sensitivity, right after getting a treatment meant to heal them?
I know it seems totally counterintuitive, but it really highlights what is happening in that acute phase. That initial 3-day window is characterized by acute inflammation. And we usually think of inflammation as a negative thing, like, chronic joint pain.
Right. You take Advil for it.
Exactly. But acute inflammation is the mandatory first step of any healing process. Your body is forcefully rushing blood, fluid, and resources to the area because you just introduced an overwhelming concentration of cellular messengers.
The local tissue is basically sounding the alarm. Like, there was even an anecdotal report in the clinical commentary about a woman who couldn't wear tight-fitting pants for a few days after the procedure because the acute inflammation and friction were literally leading to spontaneous orgasms?
Yeah. An extreme example, certainly, but it demonstrates the profound vascular rush to the area.
Yeah, no kidding.
However, it is vital for anyone undergoing this to understand that after that initial 3-day flare-up subsides, the vast majority of women don't notice much of a change at all for several weeks.
Right, because the seed is still germinating underground. The blueprint is being read, but the scaffolding hasn't even gone up yet. And the sources state that it's not until around the 3-week mark that the tissue regeneration actually starts to become noticeable.
Yeah, that 3-week mark is when a process called angiogenesis really hits its stride.
Angiogenesis.
Right, that's the physical creation of new capillary networks. So as those new microscopic blood vessels weave their way through the tissue, they bring sustained oxygen and nutrients. That is when patients typically start noticing increased natural lubrication and the beginning of enhanced sensation.
And this leads us to the 8 to 12-week mark. This is when the full effect of the initial injection reaches its maximum, right?
Yes, exactly. And if we connect this to the bigger picture, it explains exactly why practitioners explicitly mandate waiting at least 6 to 8 weeks before even considering a second treatment.
Oh, okay.
It takes a full 8 weeks for the new collagen matrix to mature and for those new nerve endings to fully integrate into the tissue.
So what does this all mean for the patient sitting in the clinic? I guess it means that if you are week 4 and you are complaining to your doctor that you aren't seeing the massive results you wanted, a good provider shouldn't just rush to give you a second shot just to make you happy.
No, absolutely not.
Because the first shot hasn't even finished baking yet.
Right. Overlapping the biological timelines in that way isn't medically sound. At 2 or 3 weeks, it is physically impossible for the new nerve tissue to have fully developed.
Wow.
The sources actually compare this cumulative nature to other PRP treatments, which I think provides great context.
Oh, like what?
Well, when practitioners use PRP for hair restoration, or treating severe acne scar tissue, or even treating Peyronie's disease in men, they never rely on a single treatment for severe cases.
Because every single session Builds a new foundation.
Exactly. It is a staircase effect. The first treatment raises the baseline quality of the tissue. You wait for that tissue to fully mature over those 8 weeks. Now, the tissue is healthier, it's more vascularized and more robust. When you introduce the second PRP treatment to that newly built baseline, it pushes the cellular regeneration exponentially further than it could have on the original degraded tissue.
Okay, that brings us to the absolute core of our mission today. We established that 65% of people are perfectly fine with just one treatment. So who exactly falls into the category that demands two?
That's the key.
Because I assumed going into this research that the two-shot protocol was basically just for older patients dealing with the effects of menopause. Is this strictly an age-based protocol?
I'm glad you brought that up because it raises an important question, and the clinical guidance is very, very firm here. No, it is not about chronological age at all.
Really?
Yeah, the clinical criteria are entirely based on tissue quality, hormonal status, and the severity of the baseline symptoms.
Okay.
You could have a healthy 55-year-old woman whose systemic hormones are optimized and who only has very mild dryness. She might only need a single O shot to reach her goals. Conversely, you could have a 35-year-old postpartum patient who suffered severe pelvic floor trauma, nerve compression injuries, and tearing during a difficult vaginal delivery. That 35-year-old might absolutely require a 2-session protocol to achieve meaningful tissue regeneration.
So it's strictly about the local tissue environment. The phrase that kept popping up in the practitioner notes was fragile, friable tissue.
Right. Friable meaning tissue that tears easily, bleeds easily upon contact, and is just highly compromised.
Ouch.
Yeah. When a patient presents with moderate to severe vaginal atrophy, a single PRP treatment is simply not going to overcome years of cellular degradation.
That makes sense.
The first shot might just do the heavy lifting of restoring basic blood flow so the tissue stops tearing. The second shot is what actually brings back the sensitivity, elasticity, and function.
The literature also explicitly highlights chronic conditions, like lichen sclerosis. And for anyone unfamiliar, that is a chronic inflammatory condition of the vulva that causes severe itching, pain, and structural changes to the skin.
It's awful.
Yeah, and because the tissue is actively fighting a chronic autoimmune response, one shot isn't going to magically reverse it.
No, it won't. For lichen sclerosis, the PRP is basically working overtime. The immune system is essentially attacking the local tissue, creating this chronic battleground.
Wow, a battleground.
Yeah. So when the PRP cytokines are introduced, they first have to act as a peacemaker. They try to downregulate that autoimmune response and decrease the chronic inflammation.
Oh, so they can't even start building yet.
Exactly. Only after that ceasefire is achieved can they start promoting actual healing. For these complex autoimmune cases, providers will proactively brace the patient for 2, sometimes 3 treatments spaced 6 to 8 weeks apart to truly get ahead of the disease process.
The data on stress urinary incontinence, or SUI, really backs up this multi-shot approach too.
Yeah.
And SUI is when a weakened pelvic floor fails to hold the urethra shut under pressure, like when you cough or jump, causing leakage.
Right.
The research confirms that for moderate stress incontinence, a 2 to 3 treatment approach significantly outperforms a single treatment.
And what's fascinating here is the statistical leap in patient satisfaction when the protocols are followed correctly. We noted earlier that about 65% of general patients are satisfied after one treatment.
Yeah.
But when you look at patients presenting with these specific criteria, friable tissue, lichen sclerosis, moderate SUI patient satisfaction jumps to around 85% after 2 treatments.
That's a huge jump.
That 20% jump is the cumulative staircase effect in action. The first round builds the scaffolding. The second round reinforces the structural integrity around the urethra to actually stop the leakage.
Okay, so knowing all of this, let's say a patient meets these severe criteria. The provider knows they need an aggressive approach, so they decide to stack therapies.
Stacking is very popular right now.
Yeah, the sources talk a lot about combining the O-shot with a radiofrequency or laser treatment on the exact same day, which apparently yields incredible results. But, and this is a huge but, if the provider does these 2 treatments in the wrong order, they completely destroy the entire process.
Oh, this is one of the most critical protocol pitfalls in the entire field of regenerative aesthetics.
Really?
Yes. Combination therapy is incredibly powerful, but only if you respect the biochemistry of what you are combining. The rule stated in the text is absolute. If you are using radiofrequency, laser, or electromagnetic therapy, the energy treatment must be done first, and the O shot must follow.
Right, because the fundamental purpose of a laser treatment on vaginal tissue is to incite controlled damage.
Exactly.
You are using heat energy to create micro-injuries in the tissue, which intentionally signals the body's natural emergency response to send in growth factors.
So the laser creates the demand for growth factors. The O shot is the supply. You are manually injecting a massive concentration of those exact growth factors into the tissue.
Right.
So if you do the laser first, you create the micro-injuries. Then you follow it with the O shot, flooding the area with the exact tools it needs to repair that damage better and faster. It is a perfect biological synergy.
Okay, wait. What happens if you reverse it?
It's bad.
Like, if you inject the O-shot first and then immediately follow it with a hot laser or radiofrequency treatment, I mean, if these growth factors are proteins and you hit them with high heat, isn't that literally like cracking a raw egg into a hot pan? You're cooking the proteins.
That is the perfect biological comparison. When you crack a raw egg into a hot pan, the heat causes the clear proteins to turn white and solidify.
Right.
That process is called denaturation. The heat permanently changes the physical structure of the protein. Think of a protein chain like a complex piece of origami.
Oh, I love that.
Yeah, and if you apply intense heat, the origami unfolds.
And once you unfold it, or fry an egg for that matter, you can never unfry it. You can't fold the origami back exactly the way it was.
Precisely. So if you inject those delicate, finely coated amino acid chains into the tissue, and then you blast that tissue with a high-heat laser device, you denature the proteins you just paid to have injected. You literally fry the growth factors.
That's insane.
The peptide chains just lose their structural integrity.
You scramble the code.
They no longer code for the message they were supposed to deliver to the stem cells. You have rendered the entire O shot completely useless.
See, here's where it gets really interesting for the patient. If you are listening to this and you've booked a combo laser and PRP treatment, you need to ask your doctor right now which order they plan to do it in.
Definitely.
Because you can have the best technology in the world, you know, a state-of-the-art Arthrex centrifuge, a top-tier fractional laser. But if your provider doesn't understand the underlying biological mechanisms, they are just going to fry the egg.
Which is why following the exact research protocol is vital for clinical success,
Right.
especially for those patients relying on a multi-step cumulative recovery process.
Oh, right.
If their provider fries their growth factors on step 1, they are never going to reach that 85% satisfaction rate on step 2.
This entire deep dive really shifts how we should view the O-shot. I mean, it isn't just some generic one-size-fits-all cosmetic filler that you just pump into the tissue. It is a highly specific, timeline-dependent regenerative tool.
It's a tool that demands an understanding of the 8-week collagen growth cycle, an accurate assessment of baseline tissue quality, and above all, a profound respect for the order of operations in the clinic.
So if you are a patient and your provider tells you that you need 2 sessions spaced 6 weeks apart because your tissue is friable, or because you are battling lichen sclerosis or moderate SUI, you now know exactly why they are saying that.
It's not a sales pitch.
No. They aren't trying to arbitrarily upcharge you for a second visit. They are literally waiting for the biological seed they planted in session 1 to mature so they can plant a second one in richer soil.
And that empowers the patient to understand their own healing timeline. When you understand the cellular mechanisms, you stop expecting the grand finale at week 3.
Because you're just getting started at week 3.
Exactly.
I want to leave you, our listener, with a final thought that really struck me while we were reviewing these sources. We've spent this entire time talking about vaginal tissue and menopause and severe pelvic floor trauma. But the sources note something seemingly completely unrelated.
Oh, the sports medicine connection.
Yes, they point out that these exact same PRP and electromagnetic therapies are currently being used to recover muscle and tissue in elite Olympic athletes, professional football players, and even million-dollar racehorses.
Because the underlying cellular mechanisms of repair are universal. Human tissue is human tissue.
Which brings up a really provocative thought to ponder. For decades, the standard medical advice for women dealing with pelvic floor dysfunction, incontinence, or painful intimacy after childbirth has essentially been, just do your Kegels and learn to live with it.
Right, which is just a deeply frustrating and historically dismissive standard of care.
It really is. But now, if we are applying the exact same cutting-edge, stacked regenerative protocols to the female pelvic floor that we use to get a pro football player back on the field after a catastrophic injury. Are we finally witnessing the end of that outdated advice?
I'd like to think so.
Are we entering an era where female intimate wellness is actually being treated with the clinical seriousness, the precision, and the funding of elite sports medicine?
It certainly seems like the science has finally arrived. Now it is simply a matter of the broader medical culture catching up to the biology.
It's about time we stopped treating these issues with a metaphorical Band-Aid and started looking at the actual blueprint. Turns out, the X-ray machine isn't broken after all. We just needed a completely different lens to see how the healing actually happens.